other for level 2. So the first topic for that is QT interval. So the QT interval is the time of the, down here, start of the QRS to the end of the T wave. So something like that in this lead anyway, in lead 1. And why do we care about the QT interval? Well, the purpose is to establish the risk for torsade de pointe, which increases with increasing QT interval. This dangerous heart rhythm is associated with long QT intervals. So the ranges. The ranges for QT are defined in terms of a QTC. The little c is corrected. The corrected QT interval is used because it turns out that that correlates with risk better than just the plain old QT interval. So I'll talk about the correction below, but the ranges are normal QTC is in a range of 330 to 450 milliseconds. A borderline elevated QTC, 450 to 500. A prolonged, significantly prolonged, 500 to 550, and then terrible, really bad QT interval would be more than 550 milliseconds corrected. So the way you measure it is you go from the start of the QRS to the end of the T. So we can look at that over here. V5, the start of the QRS to the end of the T wave. Here's the T wave. And you count the little boxes for that. And in this instance, we get 480 milliseconds because it's 12 little boxes times 0.04 seconds. And that turns out to be 0.48 seconds, which is the same thing as 480 milliseconds. So you do that. It's usually best measured in leads 2, V5, or V6. You pick the longest one. So in this case, we're working V5 over here. Another way to assess it is a rule of thumb. So in general, the QT interval should be less than half the RR interval, and if it's more, then that's abnormal and implies a long QT interval. So you're looking for a QT interval greater than half of the RR interval implies long QT. Let's look here. So we've got that QRS, this one. The RR interval is any two corresponding parts of the QRS, the distance between those. So between here and here is 19 little boxes times 0.04 equals 0.76 seconds. That's the RR interval. And the T wave, where does it end exactly? Well, we'll just use, it's easier to see in V5. Looks like it ends there. It's not super clear, but somewhere around here. And you're looking at the QT interval is clearly more than half of the RR interval, so that implies prolonged QT. The way you do the correction here is you take the QT interval in milliseconds and divide by the square root of the RR interval in seconds. So this is a little confusing because you use milliseconds here and then you're using seconds here. So I always found that a touch confusing when I was a student, but bottom line is you use seconds for the RR interval. And when you do QT divided by the square root of the RR interval, that number equals the corrected QT or the QTC. And this is called the Bazette Formula. It's the most commonly used one. And electrophysiologists will argue about what the best formula is. But the fact that they all argue about it indicates that you don't need to try to memorize all the different ones. So in this example, we've got 480 milliseconds, which we measured, divided by the square root of 0.76, which turns out to be 0.87. So 480 milliseconds divided by 0.87, and the units actually don't match up, but you just hit the I believe button and use milliseconds as the unit, and that gives you 552 milliseconds for the QTC, which is in the severely prolonged range. So that's a calculation of the QTC for the CCG. The computer will generally spit out a QTC, and it's usually using the Bazette formula. And the computer's usually pretty decent at it, but I always verify it with the eyeball by doing the rule of thumb. If I'm thinking the QT interval is prolonged, and then if it is, then I start paying more attention to calculating it myself, which is pretty unusual, frankly, for me to calculate my own QT interval. This is an important part of QT interval, is talking about the causes, because when you see it, then you might need to do something. So drugs, medications, quinolone antibiotics like ciprofloxacin, levofloxacin, many psychiatric medicines cause prolonged QT. I frequently see consults for that where a patient who's doing well on their, say, antipsychotic and antidepressant, but has a prolonged QT, what should we do? I get that consult a couple times a year. Antiarrhythmic medications can cause prolonged QT. That's a little unexpected because antiarrhythmics are supposed to prevent heart rhythm problems, yet they can predispose to heart rhythm problems. So that's a little counterintuitive. Then low calcium and low magnesium. Anything going on in the cranium, so strokes, head trauma, subarachnoid hemorrhage, subdural hematoma, those can cause long QT. Hypothyroidism, very high protein diet, and then a couple of congenital conditions, Romano-Ward syndrome and Jervell-Lang-Nielsen syndrome can do it. So when you see long QT, you've got to think, why is that happening and what should I do? We're still in the other section here. So we looked at mild hyperkalemia in the first level and showed that there were peak T waves. But with severe hyperkalemia, something in the more like greater than 7 range, you're going to get very wide QRS complexes and a lack of P waves. The QRSs are going to look really weird. So that's what we got over here. There's really wide QRSs and don't really see any P waves. Ginormous T waves too. So if you saw an ECG like this, maybe a dialysis patient or something, you'd be wondering about their potassium level. Hypocalcemia, which I just mentioned, can cause prolonged QT. And this is a whopper of a QT. Here's the QRS. Woo. There's the T wave. And it ends kind of like there. And it's way more than half for the rule of thumb. So the QTC on this, QTC of like 700 milliseconds on that. But it's terrible. So that's a hypocalcemia tracing. Let's do hypercalcemia. Feature is short QTC, and this has got a short QT right there. The ST segment itself is very short. Other features of hypercalcemia is you got this short QTC, but you've got a normal looking QRS and T wave. It all looks good, except it's scrunched into a shorter time interval. On to Dextrocardia, which is an easy one. In leads 1 and AVL, the QRSs are upside down. They look opposite of what you'd expect them to be. So it's negative in lead 1, and also in AVL, positive in F. This is going to be a right axis deviation. Here's lead 1 goes that way, and it's negative, so you know you're over here. And then AVF is positive down here. You'd be in that quadrant. You got right axis deviation. And then when you look over here at the precordial leads, you have reverse R wave progression. So the R waves are getting smaller and smaller, and they should be getting bigger and bigger. So when you see this combination, then you've got Dextrocardia. And that would pretty much only be useful on a test because it's hard to imagine these days not knowing somebody had Dextrocardia by the time you saw them. You'd have a chest x-ray or something. You differentiate Dextrocardia from limb lead misplacement, which is much more common. You got the left and right arm switched. Happens all the time. For that, you see that leads 1 and AVL are upside down, but you've got normal R wave progression. So here, negative in 1, kind of whatever, in AVF, negative in AVL. So this is isoelectric Avf is. So you're basically looking at, that's the axis, which is a right axis deviation. One of the common causes of that is limb lead misplacement. We check over here, and we've got normal R wave progression. So this is limb lead misplacement. That's a pretty darn common thing, and I get a consult for that occasionally. It's just like, if you see it's upside down in lead 1, either something major wrong with the patient, like a large old lateral infarct or right ventricular hypertrophy, or you've got limb lead misplacement. So if you see this scenario, that's what it is. Signs of pulmonary embolism on ECG can be pretty useful if you've got a dyspneic patient and it didn't occur to you that they might have a pulmonary embolism, which comes up surprisingly more often than you'd think because so many patients are out of breath in the hospital that if we suspect pulmonary embolism in every last single one of them, then we'd be doing so many CT scans. But basically, there's a high chance for pulmonary embolism for hospitalized patients, so you've always got to think of it. If your ECG shows this pattern, the S1Q3T3 pattern, which means an S wave in lead 1, a Q in 3, and T wave inversion in 3, that implies right ventricular strain and pulmonary embolism. Also, it goes along with right bundle branch block, and then patients with pulmonary embolism, the single most common ECG finding is sinus tachycardia. So if you're seeing this combination of stuff, then it's great if you can think about pulmonary embolism. So in this ECG, we've got this S wave, S1. There's a little itty Q wave in lead 3, Q3, and then the T wave inversion in lead 3, T3. S1, Q3, T3 pattern. And over here, we've got the right bundle branch block, and we have sinus tachycardia barely. Rate's about 102 beats per minute because you're looking at just a little bit less than 3 boxes. Pericardial effusion on ECG. Features are low voltage, tachycardia, and electrical alternans. That's where the height of the QRS alternates in magnitude. Unfortunately, I didn't have an ECG with this finding on it handy, so this just shows the low voltage and tachycardia. This is very low voltage. This patient really did have a pericardial effusion and ultimately got a pericardial drain put in. The rate's about 150 beats per minute, 2 boxes. And then it's wicked low voltage, where the excursion of the QRS is less than 5 millimeters in the limb leads, and it's way less than 10 millimeters in the V leads. Let's take a look at hypertrophic cardiomyopathy. Hallmarks of this are very high voltages and marked T-wave inversion. So we've got high voltages. This one goes off. Ooh, how high does it go? And then really big negative T waves here throughout. So this is an example of hypertrophic cardiomyopathy. How do you tell the difference between this and ischemia? Well, the T-wave inversion is very diffuse. It's very pronounced, and it's associated with high voltage. Digoxin effect. Digoxin's falling out of favor, but it's still used in quite a number of patients. The classic mnemonic for that is that the ST segment looks like Salvador Dali's mustache. I never really bought it, but I couldn't help myself. I had to do the whole little thing here myself. I went to the Salvador Dali Museum in Figueres in Spain. I went there in 1994. It was amazing. Absolutely amazing. The paintings are so humongous. You'd never guess that they were that big when you were looking at them in a book. It was pretty much the coolest museum I ever went to. So there's downsloping ST depression, and then the T wave kind of scoops up. And I think it looks like a lot of LVH or whatever. It doesn't really look like Salvador Dali's mustache that much to me. But anyway, you get ST depression and T-wave inversion with digoxin effect. And that can be when the digoxin's at a therapeutic level, not necessarily digoxin toxicity. All right. Hypothermia. See this one a lot. Patients in the ICU, they had an arrest, now they get cooled, and they get an ECG. Nobody's surprised to see the Osborne wave, which is zoop, that guy. It happens at the end of the QRS typically. It's also called a J wave. So that's what hypothermia looks like, and you could be tested on that. I don't know how helpful that it is clinically, because we all know it's going to be present because the patient's cooled. Okay, let's do some pacemaker stuff. This first ECG is going to be atrial pacing and ventricular sensing. So, to give you some idea about how pacemakers do their thing, the pacemaker can sit under the skin of the right side or the left side of the chest. They're making some pacemakers now that actually don't have any leads and they just sit in the right ventricle like that. They've got little tines on them to keep them in place. But those are still pretty uncommon, and most pacemakers sit outside of the heart. So there's a little box on the left or right side of the chest, and then probably the most common type of pacemaker has two leads. There's a right atrial lead and a right ventricular lead. The wires come out of the pacemaker, so this one's coming out. It goes into the SVC, and then it attaches to the right atrial wall. Usually there are little barbs on the end of it that make it stay in place. And then there's a lead, comes out of the pacemaker, SVC, through the right atrium, through the tricuspid valve, which would be here, and then into the right ventricle. It's a little surprising. It was surprising to me as a student that the lead just went right through where the tricuspid valve is, and the leaflets have to close around the pacemaker lead, but that's how it is. So this is an example of a dual chamber pacemaker because of the two chambers that are involved. The purpose for this type of pacemaker is to prevent slow heart rhythms. So if somebody passes out because they've had a sinus arrest, or their sinus node doesn't work, or there's AV block, then they could end up with a pacemaker like this. So when you're looking at pacemaker tracing, you're looking for these little narrow spikes, which can be from the voltage that's put out by the device. Typically that's what it is. Sometimes artifact can look like that, but if you see it occurring regularly, then it's probably a pacemaker. And if there's a spike here before the P wave, and then the P wave happens, that indicates that that's atrial pacing. So I made that green. It's right atrial pacing. So you see the pacemaker spike, you see a little P wave, and then you got to look at the QRS. And if you see a narrow QRS, that implies that this right ventricular lead isn't going off, because if the right ventricular lead was going off and pacing the right ventricle, then the QRS would be wide, and it would look more like this, where there's a pacemaker spike, a little P wave, and then have a wide QRS. And typically you'd also see a pacer spike before the QRS. So we're not seeing a pacer spike here, and we're seeing a narrow QRS. So that means the right ventricle is not being paced. And the pacemaker is watching, and it's seeing these complexes. It's over here, it's sensing that this is all depolarizing around it, and it knows it doesn't need to deliver a pacemaker spike there. So by sensing, then that inhibits the delivery of a voltage to pace the right ventricle. So the way we term this is atrial pacing, ventricular sensing. Let's look at this one here. Atrial sensing and right ventricular pacing. And that's this situation here where there is a P wave that happens. There's no pacer spike before the P wave, and then there's a little pacer spike, and then kind of a wideish complex. So in another P wave, no pacer spike for the atria, and then pacemaker spike for the ventricle. So the pacemaker is seeing these P waves, it's sensing them, and the pacemaker sees the P wave, and it knows that the person wants to have a QRS, so it's programmed to wait a little bit. There's a programmed PR interval, and then it delivers a pacer spike to make the right ventricle go, and then that causes the heart to contract. That's the whole purpose of the pacemaker. So that's atrial sensing and ventricular pacing, right ventricular pacing. And lastly, here is atrial and ventricular pacing. So there's a pacemaker spike here, atria go, there's a ventricular spike, and then the ventricle depolarizes, and that continues. Spike, P wave, ventricular pacer spike, QRS, etc. So that's an example of atrial and ventricular pacing. All right, that's it for level 2. That was a lot of material. Great job. See you for level 3 soon.